Good morning, everyone. Thank you so much for joining us today. This is Melody King with the Oregon Healthcare Association, and we are very grateful to our partner, Pat Preston, who will be leading the first half of this webinar today. This webinar is being recorded, so we will have access to this for our members after it has concluded. We'll post it on our website. If you have questions, feel free to send me a message using the question and answer or the Q&A feature. If you have any difficulties, technical difficulties throughout the webinar, feel free to call the OHCA office, which is 503-726-5260, or you can send me an email at mking@ohca.com, as I will be monitoring your questions and my email throughout just to make sure we're taking care of you. So without further ado, we will start with our first presenter today. It is our friend Pat Preston, infection control professional. And Pat, go ahead and take it away.
Okay, thanks. I'm waiting for a tone for the recording. Yes, waiting.
You may begin right now.
Okay, gotcha. Okay. Good morning. I am Pat Preston. I am an infectious diseases control consultant. 47 years now. I currently have a national practice, 50 states, around 20 plus corporations, and I have absolutely no conflict of interest. We're supposed to say that when you're a national presenter. I'm going to present what we're calling an update from our previous Oregon Healthcare Association webinar. And so this is not the same nuts and bolts we had a couple of weeks ago. This is the update. And I think everybody on the line understands how much we have gone through and how things have changed from we think it's coming to a state-by-state emergency, now to the national emergency, from an epidemic to now a pandemic. So we all understand that kind of terminology. I've been asked nationally when I've presented these 1-hour trainings to large swaths of corporate clients in the country, just to whom are we beholden? And in other words, of all the guidelines coming out, which ones should we be paying most attention to? And the answer is absolutely clear as a bell to me. It's CDC. One answer to why is most states, and certainly Oregon Health Authority has an Oregon administrative rule that says follow all CDC guidelines. CMS themselves state all CDC guidelines should be followed. So in my mind, it's CDC and then CMS, and then of course, any valid guideline after that or suggestion after that. So we're starting with that. Now, one update for you all. One of the most important, newest guidelines that just came out for our long-term care facility industry just got published a couple of days ago, and I'm going to say for the recording what it is. It's entitled by CDC, Coronavirus Disease Preparedness Checklist for Nursing Homes and Other Long-Term Care Settings. That's us. Skilled, assisted living, and congregate living, Alzheimer, dementia, congregate living. So the key words that you search for in the CDC website is Preparedness Checklist, long-term care settings. It's a wonderful several-page check boxes and blanks. Everybody on the call not only should get it, in my opinion, must get it. Before I go into what is the absolute update and my experience talking about the many COVID outbreaks that I've assisted with in the last week in long-term care, I'm also updating you all with the new, dated yesterday, March 18, CDC published in their publication Morbidity and Mortality Weekly Report. We refer to that as MMWR, March 18. Severe outcomes among patients with coronavirus disease, up to date. So any question you have about what are humans experiencing in the world, in the United States, that is your newest update. They give you symptoms, percentages, which I won't go into, of course, it takes too much time. And also, CDC just published yesterday the summary of the Kirkland, Washington facility that experienced the massive outbreak, and then also the deaths, and then also the many employees that got exposed and tested positive. It's MMWR dated March 18, COVID-19 in a long-term care facility, King County, Washington. In that article, they give recommendations and comments about what they saw was not in place that you want to have in place. So those are my 3 updated, brand new, that you want to hear me say are very, very interesting, and you want to, and that checklist should get. So here's what I know. The virus is not a flu. It's not a cold. This virus, as we now know, it's much more transmissible. People ask, well, what are the latest numbers in Oregon? We're up to around, last night, this morning, 75 cases and 3 deaths. So I want you to know, in my opinion, in my 47 years experience, I have not witnessed, except for norovirus gastroenteritis outbreaks, a virus that goes within a facility as fast as SARS-CoV-2, which is the name of the virus, whether it causes disease or not. I've never witnessed a virus with this transmissibility and its spreadability within a facility. So I want you to know it is not like any cold virus I've seen in 47 years. And right now there are about 6 of them by name. And I want you to know I've never seen a flu virus spread like this. So its transmissibility needs to be explained. There are great research reports stating the difference between this SARS-CoV-2, the second coming of that 2003 first SARS. The difference is the other 2, SARS and MERS, did not grow in a human throat cell. This SARS-CoV-2 apparently not only grows in throat cells, which accounts for the sore throat you keep hearing, it also grows in human lung tissue. So when you have a virus like this growing in lung and throat, that would explain the heavier viral burden, we call it. It explains the reason this is more transmissible, and it explains why the transmission is sustained throughout the world from no countries to ever how many countries we have now, which is why we refer to it as a pandemic. We hear that the hallmarks of the symptoms when this virus is growing in a human range between asymptomatic to symptomatic. And you all remember from the last webinar that I presented, and we're confirming it today, approximately 80% will have mild to moderate disease, 15% will have severe disease, and 5% will have what is referred to as critical. So mild, moderate, advancing to severe, advancing to critical. Emphasis this week is now on the mild to moderate in younger people. What we had all heard was this is a disease of the elderly. And the reason we heard that was because, and it is a fact, your latest data is about 80% in our country of people that have died, about 80% of people that have died are 80 and older, and especially those with comorbid diseases. You've heard that. That's old news. What is new today is startling. we're seeing about 40% of the total cases of the mild to moderate, and some are severe, in people that are 20 to 50-year-old. Those are not what we would call older, much less elderly, you would agree. So I watched an infectious disease presentation this morning, and that infectious disease physician said, you know what? In China, that is more or less a genetical homogeneity group of people. And maybe the reason we're seeing this spread a little bit more in Italy, and maybe the reason we should be more concerned now that we're seeing a lot of our younger people get the virus and become more symptomatic than we're comfortable with, is that there might be a genetic difference between different races. Now, that might mean that we will indeed see more asymptomatic young people / employees. It might mean that we'll see more symptomatic, and then we have to reckon with those employees now off work. So that question of, well, what symptoms are we talking about again? Fever, sore throat, reflecting information about the throat, cough, reflecting either that throat or the lungs, and shortness of breath. Here's one of our problems. Young people do indeed show the fever. What's the problem? You're seeing guidelines 100.0, 100.1, 100.4, 100.5. So I'm always asked as a corporate consultant, if I have an employee with a fever, what is the definition? I'm telling you, there are different guidelines. And so if you have an employee that presents with 100 degrees or higher, 100 degrees or higher, that's a fever. Then when you have an employee that says, I don't have a fever, but I have something in my throat, it feels different, I'm tending to cough a little bit more, but I don't have a fever, that's our problem. Some of these symptoms that we're hearing about are very difficult to sort out in our employees. You would agree. We're having trouble with that. We're sending an employee home because they have a cough. Maybe we shouldn't. We're sending an employee home because they say have a little bit trouble breathing, and maybe we shouldn't. But on the other hand, if they have a fever just by itself, maybe we should. So what I'm saying as a national consultant is we're having trouble sorting out employee work or not work issues. So let's go a little bit further. What I do know about humans is on about day 4 or 5, with a median 5-day, we are now referring to as the incubation period. It may be some humans show symptoms 1 or 2 days after infected, and you have all heard perhaps up to 14 days. So we're hearing of the 1 to 14-day incubation period. We're updating you with a mean incubation period statement that we're all agreeing on, approximately 5 days. Most people then have the mild to moderate, remember, 80%. And then those that have severe, even younger people are now being sent to the hospital. Here's an update for our elderly residents. This is an observation, and it's a documented observation in the medical world amongst your nurse practitioners and your physician providers. We're observing that our residents appear to be in that mild to moderate until about day 7 or 8. And then that mild to moderate symptomatic resident decompensates very rapidly within the day. And they will go from moderate to severe to critical very rapidly. So as I go on, I'll be speaking to you about how do we monitor elderly residents in congregate living. And keep that in mind. The monitoring is really difficult. So let's talk about that monitoring for residents right now. Here's what I have observed. Got a call from a client. Client says, guess what, Pat? We had a resident in a skilled facility who had a decrease in appetite, increase in anxiety and behavior, nothing else. Fever in an elderly person is defined as 99 degrees or higher, and this resident did not have 99 degrees. No sore throat, was able to articulate that, no difficulty breathing. And by the way, relative to pulse oximetry, that resident was not desatting. Doc said, well, we're still sending them to the emergency room because I'm just not comfortable with what I'm seeing. Goes emergency room, COVID-19 test positive. So here's the point. In our residents, some of the clinical presentation is very, very not fever, cough, shortness of breath. It could be anything like behavioral changes that are different from their normal. And again, appetite or confusion, anxiety, you want to pay attention to that. So aren't we all already monitoring fever? Yes. Temps. Shortness of breath? Yes. Now, pulse oximetry is becoming more and more popular. There are some who say if a resident has equal to less than 3% of their normal decrease, you want to pay attention to that. So I've been asked, well, then what do we do? Well, the answer is when you observe and you believe you should then report to the provider, that actually is the answer. I think we're waiting a little too long in notifying the nurse practitioner or the physician, the provider, I call them. So there's no doubt we need to do a little bit more monitoring within the day, best as we can, observing for slight, subtle, clinical, behavioral, we haven't thrown in that word before, behavioral changes, notify the provider, and then ask the provider, what should we do? We'll talk about testing a little bit later. Here's a minor update. When a provider does order lab draws, blood tests, we are seeing clinically in residents that have COVID-19, so this is a minor note, we are seeing an increase in lactic dehydrogenase. We're seeing a minor increase in liver enzymes, AST, ALT. And one of the hallmarks that I'm hearing over and over again is many of the patients/residents have leukopenia. So go to that CDC MMWR article that was just published and read more about signs and symptoms. Now, what I'd like to say to you is next, it's the testing part. Relative to testing, we've come an awfully long ways. 2 weeks ago, I couldn't get a resident tested because they weren't hospitalized. A week ago, we started hearing, we've got some tests, so have the provider call, coordinate with the local county health department. And this is what I've heard. And please don't hold me to what I've heard as being applicable to every state, every local county health department. This is what I've heard. Does us no good to call, and this is 50 states now, not Oregon only, does us no good to call the local county health department. They are so surged, they cannot get back to us in a timely manner. We all understand that. Then we'll hear the county health department calls back and says they don't meet the criteria for testing. They're not in the hospital. Hold off, we don't have enough tests. We're testing hospitalized patients that have pneumonia. So we got frustrated. And well, today we're hearing, March 19, we're hearing Roche, Hologic, LabQuest, and many of our local hospitals in Oregon, here's your update, many of our local hospitals in Oregon are now getting commercially made testing equipment, reagents, to do more, many more tests per day. So we are indeed finally getting in Oregon, and tomorrow and next week maybe, more and more commercially FDA approved testing systems. So I think that's wonderful, and I'm really optimistic more and more Oregonians and residents in our long-term care, congregate living, community-based centers will get tested. I am optimistic. So I try to listen to every webinar. I just listened to 2 national long-term care webinars back east this morning before this presentation so that I would be absolutely ready to tell you the latest. Guess what I heard? We're hearing that the equipment is arriving, the machines, the reagents are arriving, but we have no pipettes. We have no pipette tips. We're running out of minor lab equipment that essentially implements and then further allows testing. And I'm going, dang, double dang. We're finally getting the test kits, but now we're hearing we may not be able to run as many as we want because of minor little shortages like that. So let's all be patient. Everybody in the United States associated with lab testing, FDA, the commercial companies are really working 24/7 to get us our test. So you get them tested. Here's some new terminology. When they're tested, if it is positive, it is my experience and opinion that that positive test will eventually be what you then hear the second word. First, the first one's called presumptive, will eventually be the second word confirmed. I'm recommending that all of you all, when you have a positive presumptive test, consider that absolutely as scientifically sensitive, specific, and will indeed be eventually confirmed. Do not wait 5-10 days for someone to report to you that it's confirmed. Act on it as if this is really positive. This person is infected with SARS-CoV-2, the virus that causes the disease, COVID-19. So that gets us past the testing part. Now, what I'd like to talk to you about, what we do before we get that test back, because still I'm hearing the test results might take maybe a day or maybe within the day. You see, what the responsibility for ascertaining what we call turnaround time is in your lap. We have so many people on this call from so many cities, counties, that who knows what their local lab is telling you or the local hospital in which the test is done. So please, it's your responsibility right after the call, as soon as you can, identify your lab, identify their system of collecting, sending, and their turnaround time. I think you'll be surprised. It ranges from within the day to 3 days. I was told in this state, one lab system, 10 days, you'll get your results. That's quite unacceptable given what we're going to talk about with usage of personal protective equipment. So that is the problem we're having with testing. Can we get them tested? Don't know. If they are getting tested, how long will it take? So here's one tip for you all. We're still having flu. We still have, if it's a mild respiratory viral illness, probably is a head cold virus, one of the 6. So I want to tell you, this is what I know, which is the reason I was asked to present an update. Yesterday, American Medical Directors Association. Now, what is American Medical Directors Association? That's the association to which skilled nursing home medical directors belong. You have a nursing association for nurses, American Medical Association for the physicians, nurse practitioners have theirs. Medical directors, believe it or not, in our national skilled nursing homes have this. Yesterday, their guideline came out and it stated, if you see fever, cough, shortness of breath, and minor symptoms with that, like sore throat, diarrhea, some nausea, but primarily fever, cough, shortness of breath. Here's your note if you're taking paper notes. Test for flu first. Test for flu first. If that's negative, go directly to COVID-19 testing. You see, the American Medical Directors Association did not say go from flu test to a respiratory viral panel, which is running, I don't know for sure, $500, $600. And then if it's not flu, and then a couple of days later you get, it is not a head cold, then go to COVID-19. What they stated in their guideline is that you go from flu, if negative, directly to COVID-19. So I wanted to give you that update. We're still in flu season. Please not only test for flu, but test for flu first and immediately. Now I'm asked the question nationally. What if a test comes back and it is either flu or one of the 6 viruses? For example, I routinely get in Oregon, we have a RSV report, respiratory syncytial virus, or I also get reports the human metapneumovirus or rhinovirus. As of yesterday, we were told if it's flu, then don't go to COVID-19. If it's a head cold virus, don't go to COVID-19. I'm updating you. This is March 19, and you all know how things change, but I'm updating you. And what I was told this morning by the infectious disease docs that were teaching us is that yes, in this day and time, we may have flu and a COVID-19 infection. We may have a head cold virus, RSV, and COVID-19 infection. There is a movement this week to ask providers to test for both simultaneously. I'll leave that up to your individual nurse practitioners, providers, your medical directors, whether they do both simultaneously or, as the American Medical Directors Association said, flu first, if negative, then COVID-19. So I hope you all have appreciated that update on the word testing. Now I'd like to go into some infection control issues before I run out of time. We want to leave plenty of time. There is a very, very important update, less than 12 hours, maybe less than 24 hours, maybe even less than 12 hours. So take this as a note. This is extremely important. And Linda Kirschbaum and Melody King will get this for you. Just ask them. American Healthcare Association and the National Center for Assisted Living just published the new CDC guideline on the reuse and constant use by one person, the reuse of masks, gowns, and eye protection. So I want to say before I get started on infection control, to lower your anxiety and confusion, I'll make a statement. I not only believe we're going to run out of personal protective equipment, we have run out of personal protection equipment in many states, in many nursing homes, and amongst many large national corporation chain owners of both skilled nursing homes and assisted living facilities. So it's no longer theoretical. And here's a word I want to use with you all. Please, first of all, get that new guideline because it delineates, and if I would even read it as quickly as I could, would take 10 or 15 minutes, which we don't have. So get this new guideline. It gives you how and under what circumstances you may definitely use the same normal surgical face mask, sort of, in my opinion, forget about that N95 respirators. We can't get them. So we're talking about reusing one person, the normal surgical face mask, and even their gowns and eye protection. So what I'd like to say to you all is, please get that one. And then let me tell you some words that CDC uses. normally, day to day before this pandemic, we had guidelines that we all followed. And it stated after every resident usage, take them off. You've heard the words don and doff, put them on, take them off, personal protective equipment. And by golly, when the CMS surveyors were in your building, they would see that we're not perfect, and they would give us citations, and they were told now, give them immediate jeopardy citations because of this, what was epidemic, now pandemic. So in your mind's eye, does it feel like third world to you, like it does to me, that we are actually going to go, if we have more than one COVID-19 person, we'll go person to person, case to case now, directly case to case with the same personal protective equipment on? Isn't it third world that you would think that you would be putting your mask in a little paper bag or a baggie and reusing it? You think about that. Same gown, very carefully folding, keeping the outside tucked into itself, and very carefully. It's just unimaginable. So the CDC uses three words is where I'm going with this dialogue: normal, contingency, and then crisis. So in their third section of their normal guideline, and I want to read to you their guideline title. So get ready now, get ready, because I want you to know, if you really want to know what CMS says about reusage and what CDC reuses about reusage, that new document that just came out from OHCA and NCAL. Here's the terminology from CDC. Their guidelines: strategies for optimizing the supply of, so write that down, strategies for optimizing the supply of, and then you put I, or when you search gown, or when you search mask. And what you will find out is they have, and here's the key word, and I'll leave it at that, crisis. The word crisis capacity strategies. Crisis capacity strategy. So I am announcing to you, we're in a crisis. And I am announcing to you, we're now allowing reuse, and you'll determine to what extent with this new document that you can get from Oregon Healthcare Association. So really quickly, our staff is observing. We're observing more than ever before. All eyes, and you all have heard the airport statement, if you see something, say something. Boy, does that apply now. So the staff sees something. They report to the nurse. The nurse thinks it's valid enough to report to the provider. Immediately, here's step one. If that provider thinks it's a viral respiratory illness, immediately put them on droplet precautions. If the provider considers the possibility that it could be COVID-19 and orders a flu test, this is new, immediately put them on what we're now calling, March 19, special droplet precautions. Washington Hospital Association published an absolutely excellent new modification of our droplet precaution sign that you all have seen for a long time now from CDC. So I want you to write the three words, special droplet precautions. Now that includes glove, gown, mask, eye protection. Please circle eye protection. Skilled facilities, ready to go, probably have used eye protection. My national problem in the assisted living and community-based centers, we don't normally have eye protection, much less use it when we're dealing with cold and flu. So keep in mind the normal droplet precautions is now being replaced with a sign. Oregon Healthcare Association will get it for you, called special droplet precautions. Now, the beauty of the signage that you're using, because now you've got them on special droplet precautions, on the back of this new special droplet precaution sign, there are graphics showing how to appropriately and in what order to put on the personal protective equipment. And more importantly, and I'm going to stop here for a second, more importantly, how to take it off. So what I mean by stop is, I observed when we had Ebola in the world, healthcare workers died because they were not taking their equipment off appropriately. They cross-contaminated themselves, got the disease, and died from it. I observed 2003, 4, when we had SARS in the world, that healthcare workers who were used to donning and doffing routinely got the SARS-CoV-1, the first coming of this coronavirus back in 2003 and 4. They got the virus, got disease, and died from it. So I am absolutely impressed with why now we still have healthcare workers getting the disease and dying from COVID-19. And I believe it's because some of us still need to do best, not better, absolutely best, the doffing, the taking it off in exact order. And check this out. And not only taking it off in the exact order, but taking it off and then securing the gown or the mask or the eye protection and wiping them for reusage. It becomes even extremely more important to do that. So get that sign. I see a resident, I say something, we think it's viral respiratory, we have them on special droplet precautions using more equipment, personal protective equipment that we've ever done before. Well, if that test is ordered, you want to try, if you have an extra private room, you want to try really hard to move that person into a private room if you have it. Now the question that's posed to me pretty much daily now, what do we do if we have a roommate? Well, in assisted living, generally they're one person. You might have a husband, wife, and you may not be able to move them into that one extra room because as days go on, we ran out of them. So the scenario I'm giving you right now is we do have a private room and we have a roommate. Question, do I leave them there or do I move that roommate out, clean up that room, disinfect it? The answer is no. Consensus is leave that resident right where they are. Next scenario, I have a considerate case. It might be flu, COVID testing. You've got them in a private room if you have one. There are two roommates. Leave them there. Do not move them unless you have another private room. You see, we're all trying to say, leave roommates in the room if you do not have a private room. Now that's the consensus for March 19. Let's see if we can, have some continuity from week to week with that guideline. There's absolutely no doubt, and a colleague, Jack, who I just met on the phone right before this presentation, will be discussing with you 11 to 12 our state's approach to, if you are testing a resident, what do you do according to the new guideline that Jack will present to you? And I have a fist bump or an elbow bump agreement with him that I will not step on his toes, and I'll leave that kind of information around visitors to you, to Jack and for you a little bit later on. And just in case he doesn't say my little tiny tidbit here without stepping on his toes, I have clients who are standing outside the building, and especially up at Kirkland, that Life Care building, and your building, no matter what type of facility, they're standing out and holding up a phone while another employee is holding up the phone in front of the resident. We're doing Skyping, FaceTiming, any kind of digital way to email with loved ones. One of the most saddest experiences I've had during this 4 weeks of we don't have it, don't worry, to, oh my gosh, it's an epidemic, to, yep, it's here, a pandemic, was people up at the Kirkland building crying because they could not see or communicate in any manner with that loved one through the window who was dying. And I can tell you, in my outbreak situations right now, one or two cases, one case is an outbreak for maybe the wing or the floor or the whole building, depending on the state. But we're not letting family members come in to see these residents that go from mild to this decompensation to the severe to critical. And when they go to the hospital, they're not letting the family members in unless they're, and some of them, unless they're absolutely last hours of death. And then they're very careful. Again, I'll leave the visitors' issues. Now, the dining, skilled buildings, we know we're feeding inside. Assisted living, we know we're trying to. In assisted living, I'm hearing more national clients say, look, I've got to feed some of them sometimes, and some of them are really just refusing. They'll come out of that room, they'll walk right down to that dining room. So in assisted living facilities, I've got clients that are putting tables together, and they're sitting one person 6 feet away from the other person, and they're not mixing. So we are seeing some compromising strategy with 6 feet distancing in assisted living. With regard to skilled, we're already running out of employees that we're sending home, or actually, believe it or not, and I witnessed this in 1980s with AIDS. I'm out of here, man. I'm getting out of this healthcare system. We're running short of employees. So here's the point. We may have to group feed assisted feeding residents. And when we do that, we might have to separate them 6 feet apart, and still one person with a mask on feeding as many people as they can feed. But social distancing with dining, I'm hearing, is a compromise. Now, I'll give you an update with that 6 feet. We're calling a face-to-face exposure 6 feet, within 6 feet for 10 minutes of a suspected case. So that 6 feet has a little parentheses. Now, droplet precautions. Remember, we've got that special sign. Remember, CDC in a crisis situation in which we are is allowing reusage of that. So I'm hearing people wiping down their face shield or goggles with a disinfectant. Let me give you a tip. I have clients that have actually gotten all the goggles they needed. Check this out, from school supply websites. And these goggles are what chemistry students use. Remember the plastic goggles that protected eyes in the chem lab? And they ordered hundreds of them. And I go, geez, where'd you get that? So here they come, goggles, wherever you can get them. Sportsman Warehouse, shooting glasses, goggles, shooting glasses, whatever you can get that fits tight up against the cheek, covers around the edge of the eye. Here's my tip. Get them. You can use them. Wipe them with a normal disinfectant. It kills cold, flu, this SARS-CoV-2. But here's my tip. Put some Scotch tape or masking tape on the vent holes. See, a lot of these goggles have vent holes on them, and they're on the side, and you want to cover that up. So in the name of time, I've got to go on. So let's see now, the room. I told you, we talked about the strategy when we have a case. I forgot to tell you, I'm reading my notes, that we now, on that special droplet precaution sign, and today, I'm telling you, you now want to keep that door shut. Shut the door. We've had guidelines before. You need our visualization of our resident. If they're on special droplet precaution, that door is shut. And then relative to the hand hygiene, we're all still appreciating the 62% or so ethyl alcohol that we've grown up to call hand sanitizers are absolutely appropriate. 20 seconds of alcohol hand sanitizer. I used to say gel. They're coming in sprays and foams as well as gel. I want to give you all an absolute, what I would call a Pat Preston adamant request. Don't forget your thumb tips and your fingertips. I continue to watch doctors and nurses and aides and everywhere I go, men's restrooms. And we do the traditional, whether it's soap and water, plain soap, by the way, plain soap is okay. in between the fingers, around the hands, and then no attention at all to fingertips and thumb tips. They opened the door, they touched their contaminated body, and I watched them touch their finger to their nose, their eye, their face, once or twice every 2 or 3 minutes. And I just say, no wonder we have flu in our buildings. No wonder we have norovirus in our buildings. And I'm saying to you all now, no wonder SARS-CoV-2 virus is transmitting so rapidly. We're not paying attention to our fingertips and our thumb tips. Please do. I'm asked to talk about some strategies. Oregon Healthcare Association says, you know, we're a business. We all are, believe it or not, whether you think about it or not like that, but we are a business, every facility. And as a corporate consultant, I'm 50% business partner with them relative to infectious diseases control, because if they don't make money, you don't have census. We don't like that. So business now. Limit incoming virus. I'm going to go really briefly. Jack will talk to you about visitors. Limit the virus coming into your, and these are all, by the way, how do you maintain your current census? How do you maintain your current census? And one, of course, is limiting that virus from coming. So visitors, Jack will talk about that in about 15 minutes. When you do have residents and staff, monitor your staff, right? See, we're paying so much attention to monitoring the residents. Watch. There's nothing communistic, nothing big brother about watching your staff. Keep an eye on each other. And if it looks like one of your staff member might be getting the fever or clearing their throat a lot more than they normally do, if you see something, say something. The staff goes home, the resident, again, we've talked about that. Put them on droplet precautions immediately. Don't wait for a flu test to come back positive and then do it. Put them on a droplet precautions immediately. We talked about keeping the roommates right where they are. How about hospital discharges? We are now in 100% partnership with hospitals because hospitals already are surged from flu. And now with just thousands, we think, of cases already, more coming, we'll surge them way beyond capacity. And they're going to be asking you, keep this COVID person in your facility, or they will be asking you any day. It used to be tongue-in-cheek, I'm smiling. My joke used to be what I called Friday dump day. We would have the hospitals call us. In our country, Friday was a favorite admission day. So they're going to be calling you CMS and CDC, both CMS and CDC state you should take a patient with a diagnosis of COVID-19 if you're a skilled facility. Now, the assisted living facilities, that's not directed to you. They're talking about directly to a skilled facility. They're using the word should. You have everybody's permission. Now, if it's not necessary to take that person, well, then you can delay. You can maybe say, I just don't have that private room or whatever, but we're starting to see more and more COVID-19 discharges into American nursing homes. I've got one for you it's going to sound like coming out of left field. How to keep the virus out. Have those EMT, EMS colleagues putting on their personal protective equipment before they come in your building. Don't let them come in, find out what you have, and then put it on. The best of the best are putting their personal protective equipment on before they come in. Check this out. I'm not making this story up. I have an outbreak because a resident, for whatever reason, was transported. The EMT person in the back of the transport vehicle was COVID positive the next day. 5 days later, like clockwork, the resident in our facility had symptoms, was tested. So even with the best process, we're going to have a problem with the virus getting back into our facility, and of all things, from an infected EMT person. Now, if an EMT person or husband, wife, hears what I just said, that's not discriminating. It's just giving you a story that happened. So I'm recommending that if you do take a resident that is diagnosed with COVID-19 from a hospital, I am absolutely recommending that you maintain them for 1 week more on special droplet precautions. And I know what that means relative to more personal protective equipment being used. We have some scientific evidence from the world that elderly people shed the virus maybe a little longer than younger people. So even when they've recovered, some of them are having exacerbations, and we have continued shedding. Be careful with that newly discharged person. I think they're still shedding. You're going to watch these people. If it's a new admission, this is a new question. Can I admit? Should I admit? That's your question. Now, when you do admit, in some states, I just got off a conference call, in that state, they actually are quarantined. The word quarantine, all new admissions, keep them in the room for 14 days. Because we suspect any new admission, ALF, community-based center, skilled nursing home, any could be infected. So they're saying keep them in their room for 14 days. Now, I don't know what you're going to do. What I learned in the Army, when I was in the Army during the Vietnam War, we taught there's a right way, wrong way, and an Army way. Remember I mentioned that? Well, there's a right way and a wrong way, and by golly, your executive director or your administrator or your company's way, all I'm saying is there is movement afoot to keep brand new admissions out. Do not admit normally, or if you do, have them stay in their room for 14 days. Keep a really close eye on them. Next, keep the virus out of your building by no longer allowing unessential people. And guess who's on that checklist? Dermatology, podiatry, the pharmacy, pharmacists, nurses, home care people that are maybe floating building to building, salonists in your assisted living facility the salonists will go facility to facility, and you might have addition to those lists. I know I do, but in the name of the time, I refer to them as non-essential building to building visitors. And you have to be really careful, even with your delivery people these days. So I'm running out of time. I've only got about 5-8 minutes left. And really, honestly and sincerely, we're not going to have a lot of time for questions. And I hope you all have enjoyed this update. This update is based on now 2 weeks of actual in the trench. And you've heard it referred to as maybe even like warfare. I don't call it that. Having gone through the Army during the Vietnam War, I don't want to call it that. But I'll tell you, we're in very, very special, and I'll use the word crisis times. I grew up as a kid, and not as a kid, a little bit older, watching a television program called Hogan's Heroes. And I was thinking, doggone it, these police persons, fire persons, EMT, and every one of you on this phone, boy, are you what I'm now calling Preston's heroes, right? So Preston's heroes, thanks for listening. And Linda Kirschbaum and Melody King, I'd like to turn it over to you for questions, please, with the last 5 minutes or so.
Thank you, Pat. A couple of questions have been submitted online, including any clarification on what to do with employees who suspect they have had contact with a suspected or confirmed case. Whether they've had 2 reports where employees have been told by others that they've been in contact, so a contact once or twice removed. What would be your guideline on those kind of situations?
Yes. I'm glad you asked. As you all got from the 1 hour now, 55 minutes, it's like an onion. It's peel after peel after peel. Here comes the employee work restriction update. We started out saying anybody, and you all recall I said it, if you went to a high-risk country, came back, 14 days quarantine. If you went to a non-high risk, 14 days quarantine. By golly, if you've been in contact with a known case, 14 days quarantine. Guess what the new guidance is? All of them can work. everybody with no symptoms in American healthcare system is now, with newer guidance, allowed to work, and they are going to be wearing a mask every day, all day, for 14 days. So the talk about, and I know I've got a lot of corporations on this phone, and they're right now thinking, that's not what my policy says. I want you all to know that all corporate policies are absolutely being changed daily. And this one about, no, we're letting them work, there's no more 14-day restriction, is shocking all of us. You're going, what? They are living with this person that has COVID-19, they can come to work? Well, I'm telling you, there is guidance that's recommending allow them to come to work. These people that you're referring to as they were exposed 6 feet or less, more than 10 minutes, live in a family, or they know somebody that was exposed. All of those categories are now allowed to work. They're monitored, and if I were you, I would physically temp check them twice during their shift, and I would watch them like a hawk, and any kind of symptom, send them home. But until that time, they're masked for 14 days, taught to what are the symptoms you should be self-monitoring for. And so, boy, I hate to leave this with such a energy-loaded question. Check it out with your own corporate leadership. We may be allowing people to work more than ever before because of this crisis. Thanks, Melody. Next question.
Next question. May we do nebulizer treatments on residents who are suspected/confirmed with COVID-19 without access to N95 masks?
I think the word may, and this is a professional, personal opinion, the word may really should be the word should. See, and the answer is no, you should not, because if you're doing that on a suspected case, you're what we call dispelling, you're spreading really fine aerosols, and we don't have protection for that. So right now, in long-term care, there is absolute reconsideration of that procedure. Check it out with your corporation. I'm giving a negative response to that. No, don't do it. Next question, please.
Next question. The average age at this facility is 90, and many have pulsed with limited interventions or even comfort measures only. Residents may not want to be tested. How do you handle that with hospice, inflow of residents remaining in ALF who are becoming more symptomatic, et cetera?
Yes, we are handling that. And as our aging baby boomers die, and we heard a lot of them die, not only from comorbid disease, but now, remember again, 80% of the deaths so far have been in this age group we're talking about. We're going to see more and more, let them die in place, but if it appears they have that 99 or higher fever, and it appears there may be an organism and could be a virus, we're going to be approaching them very carefully, one visitor at a time, for example, and they're going to have the personal protective equipment on. So the experience that I've had so far is we healthcare workers are putting on all four: glove, gown, mask, eye protection, caring for that person who's not receiving any care at all, except we're going in that room. So, and that's my really brief answer. I do have the experience with it almost pretty much weekly. I don't say daily, but I wish I had time to talk to that person. What I do is just, we talk with all of the many different aspects of the questioner's personal issues, and we work it through, and we devise our answers. There are no guidelines sometimes published for this instance. So I do want to tell you, an article is just published. I have to give you the reference. You have to go to your medical library. It just got published today. Clinical infectious diseases. Clinical infectious diseases this week published an excellent review of COVID-19 in home care. And I want you all to know we're starting to see more and more out of hospital, out of assisted living, discharge out of skilled, discharge to home. And this is increasingly going to become a home care hospice issue. So now I think we're out of time. I don't know for sure. I feel like I'm taking Jack's time right now.
Let's ask one more question. We'll turn it over to Jack. Once a resident is tested, how long does it take to get results?
Yes,
how do you get the results?
that
How long
depends.
should it?
Yeah, presumptive for you, the first test positive we call presumptive. That takes hours to days. It depends on the lab. Does it have to be driven or flown somewhere? Is it a local hospital that's got a good one-day turnaround? The answer is, I have absolutely no idea, but you have to find out by calling your lab and asking them. And by the way, keep calling because that answer changes probably week to week anymore. Thanks all of you all. It's March 19, 2020, and I am Pat Preston. Thanks, Melody. Bye-bye.
Thank you, Pat, very much for your time today. We appreciate that wonderful information. Our next presenter today is Jack Honey from the Department of Human Services. He's going to talk about some of the various protocols that have been being sent out and directives that have been being sent out. We'll have some time for question and answer toward the end, so please feel free to continue to type your answers to me, send an email or through the question and answer feature, and I will pass them along to Jack towards the end of the webinar. Jack, please feel free to take it away.
All right, thank you, Melody. Can you hear me okay?
Yes,
right.
You are clear.
Okay, thank you. So this is Jack Honey. I'm the Administrator of Safety, Oversight, and Quality. I think most of you are familiar with who I am. I want to start by saying I don't have too long of a presentation prepared. I'm going to walk through some of the measures that we have taken here at the department to help facilities prevent the spread of this infection throughout our communities. And hopefully clarify some of the questions that we're seeing and let people know of some good resources to turn to if you do have questions, and some additional communications that we'll be setting up. Then I do want to be sure to leave a lot of room for questions. I will answer as many as I can, but as Pat mentioned a few times, things are changing very rapidly. Sometimes guidance is changing day by day. And I want to be sure that I'm giving good, consistent information. So at the very least, I can take down some questions if I'm not able to answer them immediately. So please feel free to ask anything that you have on your mind. So from SOQ and from the department, we currently have a policy out that I think everybody's familiar with, dated the 16th, which was a revised policy around visitation in long-term care facilities. We have seen tremendous efforts by all providers to implement these guidelines quickly and to protect your residents, and we greatly appreciate that. There have been a lot of questions, and we understand that right there at the front door, you are the ones that are dealing with the questions and the concerns and the pushback. So we want to be sure that we are available to help with those situations. I want to let you all know that the very most important thing to keep in mind is as we get through this situation and we deal with this illness in Oregon, we are all here working together. And that includes the department, the associations, which would be OHCA, the ombudsman, the emergency life services professionals. Everybody has been communicating very closely to be sure we're on the same page. And I really want people to know, I can't stress it enough, that we are still the regulatory agency, of course, but we are here to help. We are here to provide guidance. So please do not hesitate to contact us if you do have questions. For the most part, that is happening, and we greatly appreciate it. We have had some facilities say that they have been hesitant to call us because they're afraid of regulatory action. Only in the most egregious or necessary areas will we do that. We are here to provide support and troubleshoot with people and help problem solve. So in this visitation policy, I wanted to give people a heads up that just yesterday we sent around an implementation guide to go along with this policy. I don't know that everyone would have had the opportunity to read through it just yet, but in this implementation guide, we have tried to address some of the more frequent questions we've been getting. We additionally added some information as late as yesterday afternoon to address some questions. And this document will probably be, it will become a living document that we will be able to revise and update and share regularly, just to incorporate as more and more questions come in. I do want to walk through a little bit of it. So the design of the implementation guide is to go kind of side by side with the visitation policy and flesh out some of the interpretations in those restrictions. Some of the biggest questions that we've had are around the definitions of essential individuals. And this is very tricky. One thing that the policy does not state that I want to make very, very clear is that we really want to see people entering the building who are both essential individuals, essential visitors, and therefore an essential visit. So Pat mentioned some professionals such as dermatologists that sometimes, I don't know about a dermatologist, but sometimes there may be an essential visit that is essential to the care and well-being of an individual in your facility. Other times there may be individuals who would be essential individuals that are not there performing a necessary task. We've had a lot of questions about mental health professionals, many questions about other types of medical professionals, such as dermatologists. We've had a lot of questions about vendors, and that one's very important because there may be vendors such as electricians that are there to work on fire and life safety systems that may have an immediate impact on the safety of the facility, whereas obviously probably many other maintenance type issues are not going to be essential visits. So the bottom line there is we can't really give a fully comprehensive and clear definition or answer to these. Sometimes they will be taken case by case, and we will be able to help each facility walk through those questions as they're faced with them. We do want to be very clear that in the restrictions or limitations on facility staff, that we are allowing any facilities recruiting practices to continue. We acknowledge during this period of time that maintaining a full and well-qualified staff is absolutely essential. We don't know what will happen as the days go on, as we get through this situation. Facilities are expected to make every possible step they can to hold interviews via Skype or telephone, maybe to conduct interviews in designated areas that are away from resident areas or community areas in the facility. Obviously, you can't be doing tours or walking people through your facility, but we don't expect any facility to slow down or stop their hiring practices. And additionally, in many cases, auxiliary staff or training programs are still allowed. So nursing facilities who have CNA programs, nursing facilities and some CBC facilities that have student nurses, those may be allowed. Along the same vein, that we recognize that it's important to keep up a strong workforce. Outside medical professionals, again, I just want to emphasize we have added to the policy some of the more frequent questions that we did receive, such as emergency medical response personnel and pharmacy personnel, behavioral staff, and mental health. But again, they should be there also to perform an essential function or an essential task. And I would say that the burden of that decision would be on the professional. And we have communicated this to other industries as well, so that they should know coming in that they need to be limiting their visits to those functions that are essential. And then we have had a few questions also about resident move-ins, and we need to be very, very cautious there. I don't think that we will see too many of these, but the questions that have come up have been around residents that are moving into a facility and have a significant amount of belongings or furniture, such that typically a moving company would come and help them move. The bottom line on this is that we just cannot allow that at this time, obviously. We can't have movers coming in and out and carrying items in and out. But so far, we've only had this twice, and the facility assigned policy analyst has been very, very closely involved with the facilities and the movers to assist in this situation. And that, I think, would be the best guidance right now. If you've got people moving in and out, we try to find alternates for storing belongings, ways to get residents in with a minimum amount of belongings. And so please contact us if you do have that issue come up, and we can walk through it with you. And then additionally, the final question that we get is around end-of-life stages. And I think most facilities have probably been struggling with this one a little bit, and providers are trying to find the best way to interpret that. We at the department at this time are not putting a strict definition around end-of-life stages. Obviously, if an individual is in what is medically known as actively dying, so within the last day or two of life, that is absolutely an end-of-life stage. We also recognize that people on hospice, it doesn't always have the same meaning that it did in past years. However, we are going to open that up for consideration. That individuals on hospice, we may consider to be end of life. We have found that that this has to be considered on a case-by-case basis as well. We want to do absolutely everything we possibly can to limit exposure or potential exposure to this virus within our facilities, absolutely everything. But it is not our intention to keep loved ones apart at end of life. So what we're finding now, and we're continuing to do some research and get better guidance around how to define end of life. If there are any questions or issues or concerns from residents or their family members, that's another one that we will continue to send out updates on as we get, and we'll continue to develop the interpretation around that rule. The other key thing to remember is that when a visitor is deemed essential or non-essential at the door, the unessential individuals may not be granted entry to the facility. Those individuals who are deemed essential must then go through the screening process, which is the questionnaire about potential exposure to the illness, both observation and reporting on symptoms, temperatures, respiratory illness. They must also pass that screening, and then must use personal protective equipment when entering the facility. Screening must also happen for every individual entering the facility, and that includes staff every time they report to work. And an excellent suggestion that I heard was, this was related, I think Pat was talking about people who have come back from an area where they do acknowledge exposure. The practice of registering temperatures twice during the shift is an excellent practice, I think, to continue with. But what we are saying right now, even without potential exposure, is that every staff member is screened, and that would include taking the temperature at least at the beginning of the shift. All screenings must be documented on a form and logged. We recognize that we sent that the form out, or at least a recommended format for that with our initial policy, and we neglected to attach it again yesterday with the implementation guide. So we do have that, and we'll be sending it out again. That, I want to be very, very clear, is a suggested form that facilities may use. I know that some other groups like OHCA, CDC I was just looking at this screening checklist that they have developed. Facilities or providers, you may use any kind of screening log that does meet all of the criteria for screening that is outlined in the visitation policy, but you must keep those logs. They can be requested for review. As long as they cover all of the criteria, you are free to use any log that you wish. And keep in mind, they may also need to be updated as additional requirements are issued. Visitation alternatives. Some of the questions that we have received around that are about the extent to which facilities must go to provide this. Right now, the department's response is that it is the facility's responsibility, in accordance with resources, size, ability, to accommodate this. So some facilities have full equipment and setup to do video conferencing, to do telephone meetings and visitation, to designate visiting rooms. If a facility is providing room or equipment, the only requirement to keep in mind of, and this goes without saying, is that very strong disinfectant and infection control policies and practices must be done around those. Other than that, it would be fully expected that the facility assist with these. We have had some questions about whether staff should be using their own personal devices to accommodate these calls. Our answer is that the same level of infection control and disinfecting would apply, and that staff may not be required to use their devices or their equipment to accommodate resident calls and visitation. Activities and community outings. We just wanted to clarify that that although community outings and group congregate outings and activities are restricted, this does not include medical visits, necessary medical visits, which involves even those involving facility staff escorting residents. It certainly does not restrict facilities from coordinating and setting up transportation and accommodating visits in that way. Residents must be educated to the greatest extent possible about the COVID-19 virus, about the possibilities of exposure and the spread of the infection. This restriction also includes all congregate activities within facilities, and that does include dining. And I know that we have worked closely with many facilities that have some particular challenges around this, particularly around large numbers of residents who need dining assistance. And we will be issuing some further guidance and recommendations on that. We would be very welcome, we would be very happy to receive not only questions or communication from you if you are struggling or finding challenges with this, but also best practices. We would love to hear in this and any other areas, what are you doing to keep people safe, to meet the requirements, to observe all precautions and or then some in your own facilities that might be shared. We would love to hear that. But dining assistance is something, again, that we're working on, and we'll be issuing some additional guidance. In the meantime, we will work one-on-one with you to help develop and come up with some ideas and resources. And then finally, on suspected or confirmed cases, I do want to clarify now in Oregon, previous guidance for reporting that we had sent out was that facilities are required to report to SOQ immediately when there is a suspected or confirmed suspected or confirmed case, sorry, of the virus. And we do want to make it very, very clear that the current recommendation is, and I think Pat mentioned some potential changes to this, so we'll be looking into this. But as of today, the guidance has been that individuals who are experiencing potential symptoms of COVID-19 should be reaching out to their physicians. Residents and employees alike should be visiting the hospital if they need hospital care. They should be meeting with their primary care physicians or with your facility's medical director to, and again, this guidance is as of this morning, to consider and eliminate other possibilities such as flu and other respiratory issues, allergies. Previously, what we have seen is those physicians are then making the referrals or arranging the testing. At the point that an individual is submitted for testing of the COVID-19 virus, so to that local health authority, at that moment, we need to be informed. So for the providers, it's important to know that as soon as the local health authority is informed and that testing request is submitted, that's when to contact us. Then when that comes up, when we are informed of that step, we will consider it to be a suspected case. And in our eyes, and for all intents and purposes, we will then put additional precautions on the facility, and those stay the same regardless of whether that suspected case becomes confirmed. In the past, there were 2 layers of testing. One was the first test that came back from OHCA, and that made a case presumptive. Then a second layer of testing came back from CDC, which made the case confirmed. As of now in Oregon, I believe the 2-layer testing is still happening, but we are eliminating the word presumptive. When someone is submitted to OHCA, to the local health authority for testing, that is a suspected case. When that test comes back, we are considering it confirmed until it is confirmed as negative or passed or resolved. So at the point of suspected, what we are doing is sending out to facilities an executive order. At the very beginning, we looked at different ways to impose these additional requirements in a way that was not punitive or regulatory. So we have developed this executive order. I want to be very, very clear that when facilities receive this, you're probably all very familiar with it. It does indicate that there is a suspected or confirmed case within the building. It mandates the immediate restriction of admissions, additional restrictions on visitation, additional restrictions on congregate activities, and additional infection control training and precautions to occur within the building. And then it outlines, if you receive it, additional or just reminders really about reporting requirements. Even if you have an executive order with the restriction of admissions on your building, we still need to be informed each and every time a new case is submitted, a new case becomes suspected, and every time you receive a test result back. So anytime a status changes of a suspected case. Additionally, if you have your one suspected case and that is submitted to local authority, we will put the restriction of admissions, the full executive order, and if you get a negative test back from the health authority, what we need immediately is the written documentation of that negative test, which will be sent to you. Send that on to us and we will immediately lift the executive order. I want to be sure that everyone understands that these executive orders are not conditions in the sense that they are not going on our website. They're not going on your compliance history. It is a tool that we have developed to work collaboratively and supportively to help prevent the growth of this and spread of this illness throughout Oregon. So if people have any questions or concerns about it, we'd love to hear that. That being said, although it is not a condition, it is absolutely required. So if there are questions about how to implement it, how to observe it, we do want to hear that. if facilities are not able to implement it, we really need to work very closely together and make sure that we get you there as quickly as possible. Failure to observe it could potentially then result in a condition, but we don't want to do that. So I just wanted to be clear because we have had some questions about those. The intent is not to be punitive or disciplinary. And then I also wanted to just highlight an additional alert that we sent out about emergency medical services. We have had a lot of confusion around that. Our stance, and in collaboration and cooperation with local life and fire safety professionals, our full expectation is that anytime EMTs or other life and safety professionals are entering the facility, they need to take the immediate assumption that both they are or may be carrying the virus and the virus may be present in the facility, and take every precaution necessary with that understanding. So that would confirm what Pat mentioned, which is that they really need to be using full PPE and they need to be putting that on before they come into the facility. Now, what we want to avoid if there is an emergency situation with EMTs is that they are being delayed or detained at the door to go through the screening process. So this is the agreement that in advance they are familiar, they will be familiar with the precautions that are happening in our buildings. They will come into the building prepared using their personal protective equipment. Facilities may still do the screening, but we do ask that it is expedited. If possible, perhaps somebody can escort them back to the residence room and ask them questions along the way. We don't want them to be detained with taking temperatures, but we would want to ask, have them to report on their temperature, and they should be able to do that. So if there are any additional issues or challenges with that, we do want to continue to hear about it, but hopefully that guidance that we have shared will help, and some of the communication we've done with those life safety professionals will help as well. And then finally, before I kind of wrap up and open it up to questions, I want to let everybody know that we here at the Safety Oversight and Quality Unit are functioning now 7 days a week. So we've got live people here in the office 7 days a week to help answer questions. Now, of course, on the weekend, Saturday and Sunday, and even some weekdays, if you have a particular policy analyst or an employee here at SOQ that you work with, they may or may not be in at any given day. If you are not getting an answer or you're not able to get a response on the telephone, I would strongly recommend that you send questions or inquiries to one of the 3 email addresses that are included in the implementation guide. They are, it's nif.licensing@dhsoha.state.or.us, cbc.team, or apd.afh.team. And we will have people checking those email boxes daily and regularly so that we can get responses back to people as quickly as possible. And with that, we've got about a half an hour left. So I wanted to take some time to address, if I can, any questions.
Great, thank you, Jack. The first question, does Governor Brown or another state agency have any supply plans for assisting providers in obtaining personal protective equipment?
So this one, I actually received this question in advance earlier this morning and have been trying very hard to get the best answer I possibly can. And unfortunately, at this moment, there isn't a great answer. As you know, there are shortages everywhere for personal protective equipment, not just in Oregon, but across the country, globally, really. We are currently working very hard with state and local vendors to secure PPE for our providers and communities that are providing this direct care to long-term care settings, and additionally to our own staff. So we're really kind of struggling with the same problem, but there is a group of people dedicated right now to developing resources and finding some solutions to this. So we are working as hard as we can to find some additional equipment for you, so that you can continue to do the essential work safely. So I'm very sorry that we don't have a complete answer to that yet, but please know that on our list of ongoing questions, it is very much at the top of our priorities.
Thank you. The next question has a couple of different layers to it. When a suspected positive COVID-19 test occurs, it places a ban on admissions. How does this handled when a resident is discharged to the hospital and the hospital wants to discharge them back to the facility? Sometimes they discharge without calling first. How should that be handled?
Oh, if they are discharging without calling first, that would present an issue. And we can do some communicating with the hospital associations and the hospital groups just to ensure that they are working with us and with you as much as they can to help smooth over these transfers. The restriction on admissions in the executive order is much like any other kind of restriction of admissions that might occur in a facility, which is that new admissions are pretty much, we're saying, are restricted. Readmissions, as it says in the order, readmission of residents cannot happen without written prior approval from the Safety, Oversight, and Quality Unit. So as we continue to work through this disease outbreak, we are going to see a continued stress on hospital capacity, on hospital beds. It's going to be very, very important that we are able to take people back. Additionally, especially during this time, being able to remain in the care and comfort of your own home and your own familiar surroundings is going to be essential to people's well-being. We really do want to accommodate that in any way possible. So of course, that transfer and that return to your community would be very tightly controlled, and we would want to see a good measure of precautions around that, but we would encourage that those be allowed. So when we say with written prior approval, just give us a call or an email to your policy analyst and we can help coordinate that transfer.
All right, next question is it still accurate that the COVID-19 test has to be run twice? Does the state of Oregon always have to be the second confirming test?
I am not positive on that answer because it is changing quickly. Furthermore, this would be a question for OHCA, for the Oregon Health Authority, and I have just jotted it down so that we can get a little more clarity as well and provide consistent information. For us, once a person is submitted for testing at that first test, what we've seen so far is that the entire process is managed by the local health authority. I could be wrong on that. Correct me if I'm wrong. For our purposes, again, we want to be sure that we err on the side of caution and that all precautions are taken at every step. So we are putting full precautions at suspected through, and we look at that first test that comes back from your local health authority, And that's what we are considering as a positive result. So whether or not an additional test is done or continues to be done is not entirely relevant to our process. But it's a good question, and I will see if I can get some further clarity from OHA.
Thank you. What waivers, or will there be waivers that can be granted to waive/decrease staff hiring and training requirements prior to hitting the floor, potentially in non-resident care capacities?
Yes, so we are working on that, going through. I have in both programs, our CBC program and our nursing facility program, I have our teams just going through rule and identifying, brainstorming really all of the areas and ways that we might be able to ease up and provide additional help and support to facilities. That will be coming out. And one thing I forgot to mention is that we additionally are going to be setting up for both of those programs some ongoing and regularly scheduled webinars and Q&A conference calls. So in addition to major updates or changes to the implementation tool that we can regularly send out, we also just want to have a live forum for questions and addressing issues and concerns. So we will be sending out information about that. A lot of the questions that we have received about restrictions around staffing, I will say, just as a kind of a bottom line answer, we are not able to waive or loosen any restrictions or rule that have a direct impact on fire and life safety, on the healthcare or direct care of residents. That being said, yes, we are prepared to be as flexible as possible around staffing numbers, particularly in the non-resident care areas. We are prepared to be flexible around the sharing of tasks among staff, and the training requirements. We are prepared to be very flexible around that, but that I think will require a slightly more detailed answer. We need to go through what our requirements are and outline at what point we can allow people to be on the floor and providing direct care. But these are areas absolutely that we are willing to be flexible on. And this goes back to what I was saying at the very beginning, which is we are still regulatory, but don't be afraid to call us and ask us these questions. We're here to help. We've had some facilities that are worried about getting hit with a fine because of what they're doing with staffing. And at this point, we're going to be supportive and we're going to find the best solution for everybody. So just know that these are questions that we've had and are currently working on.
Thank you. The next question is, this person has a combined ALF and a nursing facility campus. A wife lives in the nursing facility and the husband in the assisted living. They've seen decline in the wife without the husband's visits, including a fall. Are there any exceptions to allowed inter-campus visitations if both facilities follow the same restrictions and screening guidelines?
Interesting. This is an interesting question, and I'm going to say that I don't know if the person asking this question has been in touch with their policy analyst. I would love perhaps offline to know who this is coming from so we can work on it. I don't think that our goal is going to be to keep these two individuals apart, but we would really want to look at what are the infection control practices and requirements that are happening to accommodate these visits. So the answer to the question is yes, this is a situation that we would want to take a look at and consider. And it would be developing a particular protocol, I think, to accommodate these. Does that answer it? I hope. Yeah.
Yeah, I think so. The next question is, that, Jack, you mentioned requiring essential visitors to wear personal protective equipment. Is this truly the case, as it may burn through the PPE very quickly? Can you clarify all essential visitors needing to wear personal protective equipment?
So when it comes to personal protective equipment, we are trying to research and learn just as fast as everybody else. And our recommendation still, obviously, is to follow what CDC is providing as the best guidance. We are allowing providers to inform visitors that they should be bringing their own PPE, but right now that's a problem for everybody, providers and visitors alike. An example, a question that we get often is, do they have to wear masks? But it's not current CDC guidance that people not exhibiting symptoms in general are wearing masks. So somebody exhibiting symptoms who is not wearing a mask or doesn't have PPE should not be granted access to the facility. So yeah, the answer to this one should be yes. I mean, visitors should be bringing their own PPE, or providers should be providing it. But right now there's a big challenge, and that's something that we're working on today to try to resolve. One exception to that is any state or professional staff really should be providing their own. So if you have APS investigators coming in, or complaint investigations, or other case management, we do not expect to take any of the personal protective equipment that you have for your facility. It really would be personal visitors, family that may need it.
Thank you. Let's see. We have family members who would like to visit outside the facility and are willing to practice social distancing. If we are transporting residents in and out, would that be appropriate?
At this point, if that is a safe visit in a facility or in a community that does not have active virus or an active case, so it does not have an executive order, it is safe for the resident, and both they and the family are willing. It is something that can be considered. It would have to be done very with precautions. So we had in one case an offer or a request from family that the resident just come out and sit in the car with them. And that was not a situation where social distancing could be practiced. And it was not something that we could allow. On the other hand, some facilities have room where they can set up a tent or a kind of a patio area or something outside where that can be accommodated. You really would have to look at your environment and see. Now, at this point, we can provide a lot of education and a lot of recommendation to residents, but they may choose to go. If they come back in, they can be screened. But if you want to set up a visitation area outside of the facility, it could be acceptable.
Thank you. Next question. How fast can we get written approval to readmit? Is someone available 24 hours a day to get this to us, or what is it a reasonable amount of time to expect?
Unfortunately, I can't say 24 hours a day right now, although if that becomes a need, we absolutely can. But we are here 7 days a week. And so I think that we would be able to get that approval same day, as long as we are able to get notification during the workday. And if not, it would be early the following morning. But we can turn that around pretty quickly. It just depends on the amount of additional information we need to obtain.
Thank you. The next
and
question.
And just to be very just to be very clear too on that, written approval for a readmission at this point is probably going to be no more than an email. So it will mostly be a telephone conversation between us and the facility and perhaps the hospital, and then we will just send you a quick email that approves the transfer.
If an employee has a confirmed case, but no residents within the community are a confirmed case, will the same stop placement guidelines be in place on the community due to possible exposure?
Yes. Yes, it applies both to residents and employees simply because of all of the unknown around the incubation period and the transmission of this virus. We know how easily it is spread, particularly to vulnerable older adults or those with compromised immune systems, underlying health conditions. And so the risk of having an employee that is confirmed, there's just too much of a risk around that period of time in which people were exposed. So we really would need to impose the same restrictions on that facility just until we can ensure that everybody is safe.
Thank you. Clarification of when a suspected COVID-19 test sample is sent. Is the expectation to notify DHS prior to the results of the test?
Yes, absolutely. That right when, and I think that probably has been answered just a little bit ago in this conversation, but when it's when it is submitted for a test, that means you or someone else that has suspected that this may be COVID-19, and at that point we do need notification. And I think for the most part, we have been seeing people doing that. The area of confusion that we get is after if your community has an executive order, we also need that same notification with any additional person that has been submitted for testing. So it's really continued reporting that we need.
Next question. It seems that many staff, like the policy analysts, are working remotely and only available by email. Is there a general phone line staffed routinely for any of these questions and areas of discussion?
Right now, the best, so a couple answers to that. One, we are working on it. We have a phone that we are going to be dedicating that line to addressing COVID-19 issues and immediate concerns. We're just fine-tuning some of the logistics of that because it would be one phone for all three settings, all three program types. We're trying to determine the best way to use that in a way that would allow us to get back to callers immediately and efficiently and not create a bottleneck with one person being able to staff that phone. So we are working on that. And when we do set up these webinars and Q&A, we'll send out some provider information and talk about it there again to make sure everybody has that, and perhaps some guidelines around when to use that phone. So it may be an evening and weekend phone. In the meantime, if you are calling your own policy analyst or a policy analyst that you work with and you aren't hearing back, those email addresses that I mentioned that are in the implementation guide are probably the best way to get a faster answer. Our OPAs, many of them are working remotely, but all are focused and are replying to questions as quickly as possible. My guess is sometimes you may be calling or messaging your particular OPA on a day that they are not working. And that's what we're trying to problem solve around, is how to share that with others so that we can return your call immediately. And right now it's those email addresses.
Thank you. The next question, families have frequently been asking about timeline. At this point in time, is there an estimated time frame for how long current restrictions will be in place, or is it too soon to tell?
It is too soon to tell. And as we're all aware, the governor's announcement has put restrictions on for 4 weeks from the date of that announcement, from Monday. So at the very least, these restrictions will mirror that. And that's at the very least. I have to be very open and say it's very likely that they will continue beyond that.
Looking for guidance on return to work restrictions with suspected staff. CDC has issued guidelines which involve 72 hours free from symptoms and 7 days since symptoms first appeared. Whereas prior guidance continues to change. Should we be adopting the CDC guidelines as they come out, or what is the recommendation?
I am going to wait on that answer because just in the last hour, I've heard new information and updated guidance. What we have been saying is that if people are not showing signs or symptoms of the COVID-19 illness, that they should be permitted to return to work. I believe just in the previous hour, we heard some CDC guidance that would clarify and open up the ability for people to work. It's a very, very difficult decision because obviously we want as much of the workforce available as possible without jeopardizing their health and well-being, and certainly the health and well-being of the residents. So this is a big question. Here at the state, we've actually got a few task forces that our members are combined with DHS and the Oregon Health Authority and other groups, and we are able to submit questions like this to them to get the most current recommendations and guidance. So I will submit this up to them, and we will communicate out as quickly as possible. But that being said, I mentioned earlier just the importance of looking out for provider alerts. We were a little bit concerned about using, in a normal time frame, we're concerned about using too many provider alerts because we don't want to flood you, and we know that they get kind of mixed up and lost and not always read. But right now, please just keep an eye out daily, multiple times a day, for any new provider alerts or information sending out from the department. It is our best method for communicating immediately to everybody. So there may be many of them, but questions like this that I need to go back and get some information about or get updates on guidance, the best way to answer them will be in regular Q&As that we can send out in provider alerts. So keep an eye out and we'll send some guidance on this question.
Thank you. Another clarifying question back to the readmissions from the hospital. If someone is sent to the ER and the hospital calls saying they're sending your resident back, is it okay to take them back if they weren't admitted?
Yes, but in this case, if possible, I would also just inform your policy analyst.
Thank you. If we have confirmed resident cases as well as confirmed employee cases, will the employee be allowed to work, or do they need to be off for 14 days after symptoms subside?
Current guidance is that employees should be off during that period, but I think that that's going to change, and as it changes, we will include some very detailed recommendations and protocols for it. So let me try to get a more definite answer on that and send out immediately as well.
Thank you. Local hospital labs are no longer coming into the buildings for blood draws or pickups. What should we do regarding COVID-19 testing? Are ELFs expected to collect the test samples?
So I'm not sure. So testing being done there in the building, but lab techs are no longer coming in and out. Is that, if I understand that correctly, this should be a situation where an agreement should be able to, we should be able to come to an agreement to facilitate that. Yeah, I'm not really sure. I think I need a little more information about this question. So let me jot that one down, and we'll get back to, again, whoever submitted that question. If you could contact us directly, we can get a little more clarification. Otherwise, I'll look into this and we'll send it out to everyone.
Thank you. Someone submitted a question from a small RCS with 14 residents. On Monday, they received guidance that they have no reported cases in their county. On Monday, they were offered guidance that they were not required to close the communal dining. Has that changed?
Yes. Yes, at this point, under the current visitation restrictions, we are putting limitations and restrictions on communal dining.
Okay. And the final question, in the executive order, it states we must immediately educate staff on treatment of COVID-19. Where can we find resources on how to treat COVID-19 that would be directed towards facility staff?
So right now, what that really refers to is just an absolute understanding and awareness of what any and all current CDC guidance and recommendation is. So we don't have a checklist or minimum standards or maximum standards for what needs to be trained or conveyed, but it's on the cdc.gov website. You can go in and just find daily updated information about this illness, about this virus. And so it would be just a retraining, ensuring that staff know, okay, now we aren't just a facility with no reported cases in an environment or in a state where this COVID-19 exists. We are now a facility where you may potentially be working closely with somebody who does have this virus, or so here's what you need to do. And so it would just be retraining on social distancing, on how to handle bodily fluids, if that's part of your job, how to use appropriate PPE and how it's different from in other situations. So it really would just be any current up guidance. And so we're relying on CDC for that information, and we will be doing our best to share that out as well. But we do not have a sheet or a guidance on what specifically needs to be trained.
Thank you so much, Jack, for taking so much time with us today and for taking the time to answer all of these questions. It sounds like if you have particular questions that apply directly to your building, any exceptions, et cetera, to contact your policy analyst staff, as they are working 7 days a week and can offer, can work with you on guidance and any other information that you need.
That is absolutely correct. And it does also mean that if you have cases or you have suspected cases that need to be reported, that also should be happening on weekends as well. So we're here to support and to kind of help when that happens 7 days a week.
Excellent. Thank you so much, Jack. We are so grateful to you and your team for working closely with our member communities and with OHCA during this time. We appreciate it very much. And we are grateful to all of you who are on the webinar today. A lot of the OHCA executive team is currently attending some emergent meetings. So unfortunately, some of those folks were not able to join us today. But our entire staff want to convey our thanks to all of you, your staff, your colleagues, for everything that you're doing. We are here to help you through this. OHCA is your partner, so please feel free to reach out to any of our staff members as well. Linda Kirschbaum in particular has been an amazing resource for our members. So if you have any questions, you need anything, please feel free to contact us anytime. The OHCA staff will be available and will be here for you during this time. We have recorded this call today, and we will be placing it on our website within the next few hours, so you and your team members who may not have been able to join us will have access to this information. And OHCA will continue to partner with our friends at the state to provide you with the most updated information as it comes out. And contact your policy analyst, contact OHCA. We're here for you. So thank you everybody so much for your time today.